Most men who walk into my office asking about this have already spent 3 months down a rabbit hole of supplements, Reddit threads, and products that made promises no doctor would ever make. They come in embarrassed, they sit down, and the first thing I tell them is, you deserved honest information a long time ago. The fact that nobody gave it to you isn't your fault. My name is Dr. Marcus Webb. I'm a board-certified urologist with 22 years of clinical practice, and for the last decade, I've specialized in male sexual health and reconstructive urology at a major academic medical center. I've published in the Journal of Urology, I've trained residents, and I've sat across from thousands of men, from 18 to 74, who were asking the exact same question you're asking right now. I started making these videos because of a patient I saw about 6 years ago. I'll call him Daniel. He was 34, married, otherwise completely healthy. He came in not because anything was medically wrong, but because he had spent over $4,000 in the previous 2 years on devices, supplements, and one procedure he found on a non-medical website. By the time he reached my office, he had caused measurable soft tissue damage. Scar tissue in the tunica albuginea, the fibrous sheath surrounding the erectile bodies. He hadn't made himself larger, he'd made himself less functional. That's when I realized the information vacuum around this topic wasn't just frustrating, it was causing real physical harm. So, let's talk about what the science actually says. The first thing I need to establish, because everything else depends on it, is what we mean by increase. Most men conflate two completely different things, flaccid length and erect length. These are not the same measurement, they don't respond to the same interventions, and confusing them is exactly how the supplement industry makes its money. A 2015 study published in the British Journal of Urology International, one of the most comprehensive studies ever done on this subject, analyzed measurements from over 15,000 men and established normative data for both flaccid and erect length. The average erect length was 5.16 inches. The vast majority of men who come to see me believing they have a problem are within one standard deviation of that number. I'm not saying that to dismiss the concern, I'm saying it because context matters, and because a man who doesn't know where he actually stands can be sold almost anything. Now, with that foundation in place, let's go through what has actual, peer-reviewed, published evidence behind it. And I'll be honest with you, when something has weak evidence, strong evidence, or no business being discussed at all. The first intervention, and the one with the most consistent evidence, is penile traction therapy. Most people have never heard of this, which always surprises me, because it's been studied longer than almost anything else in this space. A traction device is a mechanical external extender that applies a sustained, low-force stretch along the axis of the penis over a period of months. Here's how I explain it to patients. Think of the principle behind orthodontic braces. Nobody believes that teeth are made of flexible material, but sustained, consistent mechanical force over time causes bone remodeling. The jaw actually restructures around the new position of the teeth. Penile traction works on a similar principle. The collagen fibers and smooth muscle cells within the erectile tissue respond to sustained mechanical tension through a process called mechanotransduction, the conversion of physical force into cellular growth signals. A 2011 study published in the Journal of Sexual Medicine followed 23 men who used a traction device for a minimum of 6 hours per day over 6 months. The result was a mean gain in stretched penile length of approximately 1.8 centimeters. That's not a typo. And that's not from a supplement company's in-house trial. That's peer-reviewed. A more recent 2022 systematic review in Sexual Medicine Reviews analyzed multiple traction studies and concluded that traction therapy produces clinically significant gains in both flaccid and erect length when used consistently for at least 3 to 6 months. The critical word there is consistently. This is where most men fail. They use the device for 3 weeks, see nothing, and quit. Traction works through slow remodeling of biological tissue. Think of it like the orthodontic analogy again. Your dentist doesn't take the braces off after 3 weeks because the jawbone hasn't moved yet. The practical reality, 6 hours a day is a significant time commitment. Most men who see real results are using a clinical grade device. The Andropenes and the Phallosan Forte have the most published data behind them, and they're wearing it during sedentary activities. Working from home, watching television. The men who succeed are the ones who build it into their routine rather than treating it as an event. One important note, if you have a history of Peyronie's disease, the condition that causes penile curvature due to fibrous plaques, traction therapy is actually used therapeutically in that context, but it must be done under medical supervision. Do not self-prescribe mechanical traction if you have Peyronie's without talking to a urologist first. Here's something I want you to think about for a second, because it connects everything I'm going to tell you next. The second most important factor in functional penile length, the length that actually matters during sexual activity, is not about making tissue grow. It's about revealing length that already exists. I call it the buried penis phenomenon, and it is almost never discussed in these conversations. Significant adipose tissue, body fat, in the pubic region, what we call the mons pubis and the suprapubic fat pad, physically buries a portion of the penile shaft. In men with a body mass index above 30, studies have shown that up to 1.5 to 2 centimeters of penile length may be anatomically present but visually and functionally inaccessible because of the fat pad surrounding the base. Think of it this way. Imagine a tower partially buried in sand. The tower hasn't shrunk. You can't see it, but it's there. Clear the sand, and the tower is exactly the height it always was. A 2018 study in the International Journal of Impotence Research found a statistically significant correlation between reduction in BMI and measured increase in functional penile length, with no surgical or mechanical intervention whatsoever, just weight loss. And here's the part that should make every man take this seriously. The same adipose tissue that buries penile length also drives increased conversion of testosterone to estrogen via the aromatase enzyme in fat cells. Lower testosterone, higher estrogen. Both of those changes independently affect erectile quality and libido. You're not just dealing with a visual issue, you're dealing with a hormonal one. So when I tell a patient that the most evidence-based thing they can do is lose the suprapubic fat, I am not brushing them off. I am giving them the highest yield, zero risk, no cost intervention available to them. And I am telling them it can produce visible results in 8 to 12 weeks. I want to pause here for a second and ask you something directly. Have you ever looked something up in this space and felt like everyone was either trying to sell you something or telling you that you shouldn't care? Like you were left choosing between a scam and dismissal? If that sounds familiar, type yes in the comments. I see those comments, and I want you to know that feeling is exactly why this video exists. The third area is one I approach carefully: testosterone optimization, not supplementation, not testosterone replacement as a cosmetic intervention. Optimization, meaning identifying and correcting a genuine deficiency that is measurably impacting tissue health. Here's the biology. The penile corpora cavernosa, the two chambers that fill with blood during an erection, are composed of smooth muscle and collagen. Testosterone is directly responsible for maintaining the health of that smooth muscle. When testosterone is chronically low, that smooth muscle undergoes a process of replacement by collagen. The tissue becomes less elastic, less capable of full engorgement. The result is a functionally shorter, less rigid erection, even though the anatomical structure hasn't changed. A 2016 study in the Journal of Sexual Medicine demonstrated that testosterone replacement therapy in hypogonadal men with clinically low testosterone, produced measurable improvements in stretched penile length and erectile rigidity. The mechanism is restoration of smooth muscle health, not tissue growth in the conventional sense. The key word throughout all of that is hypogonadal. Testosterone therapy in men with normal testosterone levels does not produce these effects. It just shuts down your natural production through negative feedback and creates a dependency. This is not a shortcut. It is a medical treatment for a medical condition. If you haven't had your testosterone levels checked, free testosterone, total testosterone, and SHBG, and you are over 35 with symptoms like decreased libido, fatigue, reduced morning erections, and changes in body composition, that blood panel is worth having, not because you might qualify for TRT as a cosmetic treatment, because you might have hypogonadism, and that is a real medical condition with real downstream consequences that extend well beyond penile function. Now I need to talk about something I don't enjoy talking about, but I would be doing you a disservice if I left it out. There is a surgical procedure, it's been around for decades, called penile ligament division, sometimes called suspensory ligament release. The concept is this: the fundiform and suspensory ligaments attach the base of the penis to the pubic bone. Cutting those ligaments releases additional penile length, the portion that sits inside the body, to hang externally. On paper, it sounds straightforward. Gain up to 1.5 inches of visible flaccid length. Here is what the literature actually shows, and I want you to pay close attention to this part. A 2018 systematic review published in Andrology analyzed outcomes across multiple studies on penile lengthening surgery and concluded that up to 70% of patients reported dissatisfaction with their results. Not minor dissatisfaction, significant dissatisfaction. The reasons: post-surgical retraction, where scar tissue causes the released penis to actually retract shorter than the preoperative baseline. Loss of erectile angle, because those ligaments are what cause the erection to point upward. Penile instability during intercourse. Sensory changes, and in a meaningful percentage of cases, permanent erectile dysfunction. Let that land. The surgery with the most advertising, the most aggressive marketing, the most before and after photography, has a peer-reviewed dissatisfaction rate of roughly 70%. I have seen men come to me after this procedure who are devastated, not because their expectations were unreasonable, because nobody sat them down beforehand and showed them the actual data. The only penile lengthening surgery I will discuss with a patient as a legitimate option is penile prosthesis placement in conjunction with the Egidio technique for severe Peyronie's disease with concurrent erectile dysfunction, a reconstructive procedure for a medical condition performed by subspecialty trained surgeons. That is a different conversation entirely. For a healthy man seeking cosmetic augmentation, the surgical data does not support it, and I will never pretend otherwise. The fourth evidence-based avenue, and perhaps the most underrated, is vacuum erection device therapy, not as an on-demand erectile aid, but as a penile rehabilitation protocol. Vacuum erection devices, when used consistently over a period of months, not for sexual activity, but as a daily 10-minute exercise, have been shown in published studies to improve penile oxygenation, maintain smooth muscle health during periods of erectile dysfunction, and in some studies, produce modest increases in stretched penile length. A 2006 study in the BJU International followed men using vacuum therapy post-prostatectomy and found that men who used the device regularly had significantly better preservation of penile length compared to the control group. Again, the analogy I use with patients is exercise. You don't go to the gym once and leave with muscles. You create a consistent stimulus. The tissue responds over time. A vacuum device used consistently for penile rehabilitation works on the same principle. Regular engorgement cycles improve tissue health and maintain elasticity in the corpora cavernosa. The difference between a medical-grade vacuum erection device and the novelty products sold online is significant. Devices with a pressure-limiting valve are essential. Excessive pressure can rupture penile blood vessels. This is not a toy. It's a medical device, and it should be used as one. Here's something I want you to sit with for a moment. Almost everything I've described today, traction therapy, weight loss, testosterone evaluation, VED rehabilitation, requires time. Months, not weeks. Consistency, not intensity. A routine built into a daily life, not a 30-day challenge. That is completely incompatible with the way this topic is marketed. The supplement industry, the device industry, the surgical industry, they all profit from urgency, from the belief that there is a faster path, from the shame that makes a man not want to spend 6 months on something when he could spend 6 days. But Daniel, the patient I told you about at the beginning, what he needed wasn't a faster solution. What he needed was someone to sit across from him 2 years earlier and tell him the truth, that the evidence-based path existed, that it required patience, and that it was worth taking. He came back to see me a year after I first met him. He had spent those 12 months doing it right: traction therapy, weight loss, testosterone optimization. The soft tissue damage from his previous interventions hadn't fully reversed, and I was honest with him about that. But his functional erection quality had improved significantly. His confidence had changed in a way he said was hard to explain. He told me he wished someone had made a video like this when he was 27. So, let me give you the honest summary. Not of what will definitely work for you, because I don't know your body, your baseline, or your health history, but of where the evidence actually points. Penile traction therapy, used consistently for a minimum of 3 to 6 months, has the most peer-reviewed evidence for modest but real gains in stretched and erect length. Weight loss targeting the suprapubic fat pad produces functional length improvements with zero downside and significant hormonal benefits. Testosterone evaluation is worth pursuing if you have symptoms of hypogonadism, not as a shortcut, but as medical care you may genuinely need. Vacuum erection device therapy has a role in long-term penile health maintenance and rehabilitation, and everything that promises results in days, the supplements, the topical products, the viral routines, has no peer-reviewed evidence behind it. None. The one thing I want you to do tonight, before you close this video and before you search for anything else on this topic, is this. Write down the questions you actually want answered about your own situation, about what's driving the concern, about what enough would actually look like for you. Because in my 22 years of practice, the men who come in with the clearest sense of what they're actually looking for, they're the ones who get the most useful answers. And they're the ones who leave my office feeling like they got something real. If this video gave you something real, share it, not for my channel. For the man in your life who's been down that same rabbit hole and never got a straight answer, he's out there, and he deserves better information than what he's been finding.